The operating room is the center of the operating room complex. In this course, the operating room complex, as well as the operating room, are discussed in detail. The complex is divided into zones. A specialized air management system contributes to a gradation in cleanliness within these zones. In this course, the standard components of the OR, zoning within the OR complex, climate control, lighting, electricity, supply of gases, and fire safety are discussed. The patient is positioned in the center of the operating room, so he is optimally surrounded by the operating team and medical instruments and devices. A panel above the surgical table ventilates the sterile field with filtered air. In order to administer anesthesia easily, the anesthesia machine is usually at the head of the surgical table. If it is required to reposition the surgical table, the anesthesia machine can be moved as well, in order to maintain a close distance to the patient's head. The machine should ideally be located close to the door, allowing quick access for the anesthesiologist in case of an emergency. Electrosurgery is integrated into modern surgery and part of most procedures. The electrosurgical unit is therefore a standard component of the operating room. A suction device is a standard component of each operating room. Both the surgical team as well as the anesthetic team use the suction device. During surgery, it might be used for evacuating blood, other fluids, or smoke. The anesthesiologist might use the device to clear the airway. The suction device is connected to an integrated vacuum system. At least one, but usually two operating lights are installed above the surgical table. The movable arms and tiltable light head allow for creating any desired light field. The lights can be adjusted by any team member. The handpiece should be covered with a sterile cover. Devices which are needed in order to perform an endoscopic procedure are a light source, a camera processor, and an insufflator. For a more detailed elaboration of this, refer to the course Endoscopy Tower. The components are located either on a built-in column as a fixed part of the operating room or on a separate mobile tower. Besides the monitor on the endoscopy tower, additional fixed monitors might be available in the operating room and can be placed in different positions. Take note that the endoscopy tower is not a standard component of the operating room, but widely used since the introduction of minimal invasive surgery. To have immediate access to all required disposables during the procedure, a utility cart must be present in the OR. There are two utility carts. One for the anesthesiologist, containing, among others, medications and tubes, and the utility cart of the scrub nurse, containing disposables like dressings and gloves. A separate cabinet is often present for all types of sutures. The body temperature of the patient should be kept stable, and hypothermia should be prevented. The use of warmed blankets and fluids during long procedures is advised. These items are stored in a warmed closet, which may be integrated into the OR, or outside near the OR. A refrigerator is used in the operating room complex, especially for keeping medicines at the desired temperature, or to preserve specimens. In general, the surgical team consists of 6 members. Surgeon, assistant and scrub nurse are part of the sterile team. A circulating nurse is present in order to assist the sterile team. This may be with handing over additional surgical implements if required during the procedure, as well as taking care of other patient and implement-related tasks during the pre, per, and post-operative phase. Anesthesia is provided by the anesthesiologist and the nurse anaesthetist. The position of the surgeon at the surgical table depends on the specific procedure to be performed. It may also depend on the dominant hand of the surgeon. A right-handed surgeon will probably stand on the right side of the patient if the surgical site is centrally located and an open procedure is performed. During endoscopic procedures, the position of the surgeon is usually opposite to the surgical site. The monitor is usually located above the surgical site, allowing easy handling of the camera while looking from a certain angle into the direction of the screen. Note that the screen is usually closer to the surgical site. The assistant usually stands in front of the surgeon during open procedures and next to the surgeon during laparoscopic procedures. The ideal position for the scrub nurse at the table is diagonally across from the surgeon. This allows for easy handing over of instruments from the scrub nurse to the surgeon. The anesthesiologist and the nurse anaesthetist are logically located at the head end. In order to control bioparticulate matter in the operating room environment, a specialized ventilation system has been developed. It is usually located in the center of the ceiling, right above the surgical table, and is designed to provide a clean, filtered downflow of air, while displacing the ambient air in the room in order to prevent particles carried along by air currents from moving towards the sterile area. This type of ventilation is also known as laminar downflow. A laminar flow diffuser panel concentrates and directs a downward airflow, concentrated downflow. Polluted ambient air is hereby displaced by an invisible column of cool and filtered clean air. At the same time, a series of vents located in the walls of the operating room provide active extraction, whereby the air is directed via the return air zone located outside the walls of the operating room into advanced filters above the ceiling. These filters are high-efficiency particulate air filters, HEPA, used to remove the particles present in the air. The operating room should have a minimum of 15 total air exchanges per hour. Doors to the operating room should be kept closed in order to maintain correct ventilation, airflow, and pressure. The temperature within an operating room should be kept between 18 and 20 degrees. 66 to 68 Fahrenheit, with humidity between 30 to 60%. Supplied filtered air is usually around 19 degrees, but can be adjusted if necessary. For example, higher temperatures are preferred for children, since children's bodies' heat decreases more quickly. Working in a cool environment reduces the chance of the sterile team getting affected by the heat, caused by the gown, gloves, masks, and operating lights. A sweaty forehead endangers sterility when sweat droplets fall into the sterile area. Furthermore, research shows that a cool environment improves concentration and prevents irritation within the team. Also, bacteria, viruses, and other organisms grow and reproduce more slowly when subjected to lower temperatures. Humidity should be maintained between 30 and 60%. Higher humidity may cause condensation of ambient moisture, which, as explained earlier, may jeopardize sterility. Lower humidity, on the other hand, may generate static electricity, which may lead to electrical shocks or fire. An operating room complex is divided into different zones. 4 zones can be described in an operating room complex: sterile, clean, protective, and disposal zone. The positive air pressure within the operating room and the other zones prevents polluted air from flowing towards cleaner air. The air pressure within the different zones decreases, going from the sterile OR environment to the disposal area. Operating rooms and sterile preparation areas belong to the sterile zone. In the sterile zone, the highest level of aseptic conditions need to be maintained. Air pressure within these areas should be greater than that in the surrounding corridor and adjacent areas, minimizing the amount of corridor airflow entering the sterile zone. The clean zone is designed around the sterile zone and connects the protective zone to the sterile zone. Clean corridors, store areas, and rooms for OR staff are included. The clean zone is only to be entered by staff wearing proper clothing, also known as surgical attire. A clean zone is surrounded by the protective zone. This forms a protective area between the clean area of the operating room complex and the rest of the hospital. Dressing rooms, the reception area, and waiting areas are part of the protective zone. Soiled instruments, used linen, and operating debris are taken out via the disposal zone, where it is taken away by the utility service or sterilization department. Sluices within an operating room complex help to prevent unwanted air movement. They also mark the different zones and ensure a gradual transition from high to low air pressure areas. Some of these sluices consist of 2 doors with a space in between. Unless there is an emergency, the doors are not opened simultaneously to maintain the pressure gradient and prevent air from flowing from dirty to clean. Do note, the cap should be removed when leaving the operating room complex. Given the nature of work in the operating room, there is a high requirement for optimal lighting. Ambient light and operating theatre light are discussed. Ideally, the ambient light within an operating room is white in order to properly visualize the colors of the human body. It is adjustable in intensity, which may be necessary during minimally invasive surgery. This operating room consists of a large panel with fluorescent light located above the sterile area. In this way, light is projected from many directions, which prevents the formation of shadows on the surgical site. Modern operating rooms have green ambient lights, which are used during minimally invasive surgery. Green light enhances visualization while allowing for adequate ambient light. Since staff members are generally unable to leave the operating room complex, some natural daylight is preferred. Windows that give a visual appreciation of the outside world can be considered in order to contribute to pleasant working conditions. Usually, 2 tiltable light heads are fixed to the ceiling via movable arms, allowing the sterile team to make adjustments to the distance and the position in order to properly illuminate the surgical site. Note that the arms are in a W shape. This position ensures that the lights are easy to maneuver. Either a reusable or disposable cover can be used. The operating light consists of several lamps with hollow mirrors inside in order to create a converging light beam. The convergence of light beam can be controlled by the sterile team by turning the handle in order to move the mirrors towards the center or away from the center. In the operating room, this is also known as centering of light. The light beam can be centered on the specific area of interest. An operating light should be designed in such a way that minimizes the disturbance of the laminar downflow. Both size and shape are taken into account, as a large flat surface disrupts the air currents more than smaller and more convex shapes do. These lights have a large surface, but are convex-shaped on top. The operating room is powered by an isolated system, also known as a galvanic system, meaning there is no contact between the electrical circuit inside the operating room and the electrical circuit outside the operating room. The supplied electrical current ends in an induction coil, which may be located inside the wall of the operating room. Voltage is still present within this coil and transferred through a non-conducting intermediate layer to a second coil, which is located inside the operating room. In this coil, voltage is converted back into electrical current. The grounding system is an exception to the strictly isolated system of the operating room. Ground wires must be able to leave the operating room directly and are therefore the only permitted galvanic connection to the operating room interior. Usually, the earth connection is only integrated in the alternating current cable. In the operating room, different rules may apply because the conventional earth connection may disrupt the working mechanism of the isolated system. In an operating room, devices may therefore be secured with an external earth cable, which can be recognized here by its green-yellow color. The use of gases is an integral part of surgery, where it has both anesthetic and surgical applications. Examples are oxygen for ventilating the patient during a procedure, or compressed air for inflation of a pneumatic tourniquet cuff. Gas cylinders may be used, but more commonly the gases are supplied from a central system. Gas connections which should be present within the operating room are oxygen, nitrous oxide, and compressed air. Vacuum is also supplied from a central system. A piping system transports the gases from large storage tanks to the operating room. Pressure drops and decreasing vacuum is monitored by detectors, which are installed at a central point within the operating room complex. Within the operating room itself, gas pressures are usually checked by the nurse anaesthetist during the preparation of the anesthesia machine as part of the daily work. For safety reasons, the hoses have their own recognizable color, and the different connections only fit in one way. In order to prevent connecting the wrong gas, colors may differ from the colors shown. With a view to the design and layout of the operating room complex and fire prevention, the correct location for fire extinguishing equipment, the installation of fire alarms, and a location where gas supply can be turned off must be determined. One of the safety measures is the division of the complex into compartments. Each separate compartment should have its own fire extinguisher, fire alarm, and gas shut-off valves, which here are located inside this gas management system. The location of the closet where fire extinguishers are stored inside the corridor should be clear and must be kept free from devices and other materials. Fire, smoke, and heat sensors should be located throughout the hospital. Also, when activating a pull station, an alarm is activated, and the hospital fire response plan should immediately go into effect. A specialized team determines what additional resources are required and if evacuation is necessary. Shut-off valves are used to stop the flow of gases into the operating room. Responsibility for turning off the gas supply should be predetermined. Commonly, the anesthesiology departments are responsible for turning off the gas supply. When the operating room is equipped and built as mentioned, a safe environment for performing surgery is secured.